All right, this is a lecture on cardiac pharmacology. To be honest, I'm not even sure where this PowerPoint came from, but I found it on the files on my computer that I must have downloaded last year. So here it goes, a little bit on cardiac pharmacology. So first of all, we have our antiarrhythmics. So you understand that an arrhythmia is an irregular heart rhythm. So normally we know that our heart has this particular rhythm. You see those little the little line that goes up, has a little bump there, and then it goes down, and the QRS wave, and all that stuff like that. So an arrhythmia is when it has a bad or irregular rhythm. So these antiarrhythmics are drugs that are designed to treat some of these arrhythmias. And we know that the conduction of the heart, the electrical conduction of the heart, works through these different, sodium channels, also some calcium channels, different things like that. So the class 1 fast sodium channel blockers are these ones that we're going to be talking about first. So these are class 1 fast sodium channel blockers. You think they're 1 because they're fast, so they come in first, or the first thing that everybody gets in their kitchen is salt, because salt is so important, sodium. I don't know how you want to think about this, but these are class 1 fast sodium channel blockers. So there's class 1A, class 1B, and class 1C. We'll start here with class 1A. So I remember when I was young, when I was learning my ABCs, one thing that people would say is they say, hey, if your zipper is down, they say XYZ PDQ, and PDQ stands for pretty darn quick. So these are the fast sodium channels, and these are pretty darn quick. It just so happens that PDQ, pretty darn quick, that maybe will be a way for you to remember the 3 class 1A, if you're learning your ABCs and you're young, drugs that you use. So the first one is procainamide. So procainamide, and this one is with synchronism. So you remember synchronism. How can you remember that? Maybe if you have some cocaine, you want to dump it down the sink. This kind of sounds like synchronism. So cocaine, procaine, dump it down the sink. Next here, disopyramide, and that's with heart failure. So disopyramide, heart failure. You'd think when you went to go look at the pyramids, it was so big that you had heart failure. So disopyramide, you died at the pyramids from heart failure. Next is quinidine, and this has reversible SLE-like symptoms. So everyone remember that. Next is class 1B. And the B, so remember A comes first in the alphabet, B comes later, and class 1B, these are best post myocardial infarction. So post MI, targets already depolarized Purkinje fibers and ischemic tissues. So this drug, let's say in your heart, you have these Purkinje fibers that part of the structural thing specifically in the heart, and the class 1B are going to go to those that are already depolarized, which means they've already fired. So this is going to be after you've already have that myocardial infarction. And one way to remember this is remember this movie Princess Bride, P for Princess Bride. In there, the guy talks about an MLT, mutton, lettuce, and tomato sandwich. And that guy looked really old that was talking about this. He looked like he maybe have already had a heart attack. So in Princess Bride, the guy talked about MLT, mutton, lettuce, and tomato. And this is post-MI. The guy was so old, probably already had a heart attack. So that's a way to memorize this, PMLT. So first of all, the mixilotine. So if you get Mexican food, you're going to get GI upset. Okay, you're going to get heartburn, Mexican heartburn. Mixilotine, GI upset. Lidocaine, everybody knows what that is. That's like an anesthetic. Toconide, you think pulmonary fibrosis. You ever had anybody pull your finger or whatever? You think of this when they're pulling your toe. Okay. You're pulling your toe, and it is pulmonary fibrosis. So tokenide pulmonary fibrosis. Maybe another way you can think of this is this kind of looks like two. So you've got two lungs. I don't know, however you want to think about that. Next is phenytoin. Hopefully I'm pronouncing this right, phenytoin, whatever. And so side effects with this one are, by the way, all the SE here stands for side effects, if I understand correctly. The side effects of phenytoin. Phenytoin is used as a person's having seizures or whatever. You can give them phenytoin and treat that. Also has a lot of CYP 3A4 interactions. But one of the side effects of taking phenytoin is it can make you look kind of funny because you start growing lots of facial hair. And if you're a girl, that could look kind of funny. So phenytoin. Also, it can make you look funny because you get gingival hyperplasia. So your gums get all big. So phenytoin makes it look funny because you get facial hair and big gums. Next is class 1C. So class 1C, these are actually contraindicated, C for contraindicated, post-myocardial infarction. They are a last resort, zero-order kinetics. So you have first-order kinetics is where, it goes away at this, breaks down slowly. Zero-order kinetics, you learn that more. I guess that's not time to talk about that, but it's just the rate at which it breaks down is a certain amount each second. And the side effect of these things is that they are proarrhythmics. Okay, so these are all proarrhythmics, which means they cause arrhythmias. All right, and enconide, flecainide, and propafenone. Also, propafenone is also a beta blocker. So he's a pro because he does two things. He is a fast sodium channel blocker, but he's also a beta blocker. Yep. All right, moving on here. Next, we have some more antiarrhythmics. These are class 3 potassium channel blockers. So remember, the first ones we're talking about were the fast sodium channel blockers. These are 3, and they're potassium channel blockers. So 3, when you think of 3, think of potassium. And one way you can remember this 3 is that 3 kind of looks like a butt. And in potassium is the word ASS, which looks like a butt, which looks like a 3. See that 3 there is a butt, and potassium, okay? So class 3 is potassium, okay? And there are 2 of these, and one actually has the word butt in it. Ibutylide, or 3, potassium, ibutylide, and amiodarone, okay? And you remember this amiodarone because butts have really strong odor, so amiodarone, okay? So ibutylide or ibutylide and amiodarone for potassium channel blockers, class 3. Side effects, quite a few things here. So your thyroid controls your metabolism, things like that. So the effects are going to be hypothyroidism, hyperthyroidism. So that means when you're giving this to somebody, you need to check their thyroid stimulating hormone levels, the TSH. Thyroid stimulating hormone levels are going to be your best indication for how your thyroid is operating, because if the thyroid stimulating hormone levels are really high, it means that your thyroid maybe it's not functioning very well, and so this is trying to put out more to get it to go faster. And if it's really low, whatever. Anyway, there's different ways you can check this. And another way you can think about that is metabolism has to do with people usually like to work out to make their butt get smaller. So potassium, class 3 butt, and their thyroid has to do with their metabolism. Ibutylide and amiodarone. So also, this can be associated with hepatic necrosis, corneal clouding, which is where like the cornea of your eye get all clouded. It also blocks some CYP 450, which increases the levels of warfarin, which is a blood clotting drug, or one that prevents that. Estrogen, phenytoin. If it does phenytoin, I know right there it must be 3A4. Must be at least one of the things it does, because 3A4 is associated with phenytoin, if I'm remembering correctly. Theophylline and digoxin. and it can cause Smurf syndrome. Okay, blue, make you look blue. So maybe you could think of the little blue 3, a little blue Smurf butt, causing Smurf syndrome. Okay, now we're getting on to class 4 calcium channel blockers. So these are also antiarrhythmics. And well, you know that 1 is sodium, because it's the first thing everybody has in their oven. Next, class 3. 3 looks like a butt, and it's potassium blockers. And 4 is for calcium. Okay, however you want to remember that. 4 is for calcium. So this is, there's some that are cardioselective and there's some that are vasoselective. So cardioselective, cardio is heart, so this must be selective for the heart. Vasoselective is the veins, so this must be selective for the veins. The ones that are cardioselective are diltiazem and verapamil. So diltiazem and verapamil. And the ones that are vasoselective are going to be the pines. Now, pines kind of makes me think of trees. When I think of trees, I kind of think of tree roots. And some of you could think here this is vaso or vein selective because it's the pines, the vines, like the blood vessels. Also, nimodipine. And nimodipine reduces mortality post-subarachnoid hemorrhage. So remember, up in your brain or in your meninges and all that kind of stuff. Okay, you've got the arachnoid, and subarachnoid, and dura, and pia mater. Okay, this is post subarachnoid hemorrhage. So after a person has had a subarachnoid hemorrhage, you give them nimodipine. Some of the side effects with this is going to be constipation. Well, constipation makes a lot of sense because we know that calcium is what causes you to become constipated. If somebody has too much calcium, they get constipated. So you can remember that. Calcium, constipation, those just go together. And then you also can get edema, flushing, and cardiovascular effects. Next is antiarrhythmic. So these are antiarrhythmic nitrates. So again, this is treating arrhythmias. In this particular case, this is the nitrate class. And I have another lecture I did that talks quite a bit about nitrates, but you can go look at that if you want. So just some really quickly, nitroglycerin, isosorbide dinitrate. Essentially what nitroglycerin does is it's going to cause vasodilation. So your veins are going to go from being small to big. Method of action, vasodilation, release of nitric oxide in smooth muscle blood cells, increases cyclic GMP. Cyclic GMP is the thing that causes vasodilation. So nitric oxide in the smooth muscle cells increases cyclic GMP. Cyclic GMP is going to increase the vessel diameter. And apparently it targets the veins before the arteries. So veins first, arteries second, which is backwards. There's a thing, nitroglycerin is backwards. I don't know if that's really backwards or forwards. It's just what popped in my head. So veins before arteries, veins first. Clinical use, person's having angina or pulmonary edema. Okay, this is where blood's backing up into, or fluids backing up in their lungs because the blood pressure is so high in there. Side effects, they can get reflex tachycardia, which means basically you take this medication and it works at first. They get a normal, heartbeat, but then afterwards their body like compensates for it, and tachy is like fast, and so it like kind of bounces back and it ends up going. So it goes, oh, you take it, oh, it's working great, and all of a sudden, beep, 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 it goes way faster than before. Also, I mean, if it's making the blood vessels get bigger, that can push on your brain and give you a headache. Also, it can make your blood vessels, your veins get bigger, it can make you get flushed. Also, of course, this just makes sense. If you increase all the blood vessels in your body, is the pressure in your blood vessels going to be very big, be very strong? Well, no, it's going to be smaller because, it's going to be low pressure because all the blood vessels are so big. It's just like if you had a bottle of water and you took all the water out, is there going to be very much water pressure in there? No. And then Monday disease, where they develop tolerance. So there's going to be beta 1 and there's going to be beta 2. So got to remember these, just some basic effects here. Beta 1, what are they going to do? They're going to increase heart rate. So your heart rate's going to go faster. It's going to increase contractility, so the heart's going to contract harder. It's going to increase glucagon release, which makes sense because, I mean, if you're doing things harder and faster, glucagon is where you store energy. It's got to release more energy. It's going to increase renin release. Remember the renin, angiotensin, aldosterone pathway. So the deal with all this is basically what you have is you have angiotensinogen. Angiotensinogen is converted into angiotensin 1, and then angiotensin 1 is converted into angiotensin 2. Well, the thing that turns angiotensin comes out of the liver. The things that turns angiotensinogen into angiotensin 1 is renin. And renin comes out of your juxtaglomerular apparatus in your kidneys. Okay, so this drug here is going to increase renin release. So, or beta-1, sorry, the beta-1 drug. This beta-1 receptors or whatever are going to increase renin release, which means it's going to make more angiotensinogen turn into angiotensin 1. And if there's more angiotensin 1, it's very likely there will also be more angiotensin 2, and angiotensin 2 is the thing that causes vasoconstriction and, you know, more aldosterone release and all that kind of stuff like that. So next, it also causes increased lipolysis, breakdown of fat, which makes sense. You need more energy, so it's going to break down some of this fat to give you more energy because everything's beating fast and going. You're going to be number one. You got to be going really fast here. And then also increases vasoconstriction, which again makes sense. Muscles are tightening down, your contractility is increasing, your heart rate's increasing, everything. So this is all stuff that increases your blood pressure. Okay. Now let's go over to beta 2. So beta 2 does some things a little differently. Beta 2 is going to increase aqueous humor. So aqueous humor, aqueous water, so more humor. I don't know if this is talking about your eye. I don't know what this is talking about, but you have more fluid. Increased contractility. So similar to the other one, it's also going to increase the contractility of your heart. Your heart's going to beat harder. Also, this one's different here, that it increases insulin release. Now over here, this increased glucagon. Glucagon meaning it's in the situation of beta 1 with glucagon, it's like, okay, we got some energy stored here as glucagon and fat, and everything's going really fast. We need to release, we need to break down this glucagon, release the sugar so you have energy. In this case, insulin says take all the sugar in your blood and store it in fat. So increases insulin release. So this is the opposite. Beta 2 does exactly the opposite in this case. So it increases insulin release, which means it's going to take more energy out of your bloodstream, the exact opposite of the glucagon effect. It also relaxes the uterus. So if there's a woman who's about to have a baby and it's going to be preterm and you want this to calm down because you don't want the baby to come out yet because we're not ready yet because the baby's not done cooking yet, you want to give her this beta 2 stuff that's going to affect beta 2 because it's going to relax the uterus. Also, this can be involved with bronchodilation. So if a person, let's say they're having an allergic reaction and everything's tightening down in their throat and they can barely breathe, well, if you give something that's going to affect beta 2, it can cause the bronchospasm to dilate and relax, and everything, so they can breathe better. And it also is going to increase vasodilation, which is again exact opposite of what beta 1 did, which was vasoconstriction. So beta 2, the type 2 beta, he's all relaxed, he's storing his sugar. This guy, he's all fast and everything's going quick, and he's releasing all of his sugar to be used. Main thing that's kind of similar amongst these two is they both do increase contractility. Okay, so now we're going to talk about class 2 beta blockers. Increase end diastolic volume and ejection time, EDV and ejection time, and they decrease blood pressure, contractility, heart rate, and heart oxygen consumption. So these are class 2 beta blockers, okay? Class 2 beta blockers. So what we're going to have here is we're going to have some beta 1 agonists. We're going to have some beta 2 agonists. Agonist means that it causes it, okay? This is going to promote it. An antagonist is something that stops it. So this is going to be basically stimulating beta 1 and drugs that stimulate beta 2. So these are class 2 beta blockers, okay? So the beta 1 agonists, side effect is going to be flushing, angina, and arrhythmias, or angina, however you want to say that. This is going to involve dobutamine, where the effect with dobutamine, the effect of beta 1 B1 is bigger than that of beta 2. And you use this for treatment in cases of congestive heart failure. So the person has congestive heart failure, you want to give dobutamine, okay? And it's going to affect beta 1 more than beta 2. So if you remember what beta 1 versus beta 2 did, look back at this. There's beta 1, there's beta 2. That's going to be the treatment there. Also, you have iso. Iso means same, okay? Like isometric, same, okay? So that means beta 1 and beta 2 are going to be equal, okay? So isoproterenol, beta 1, beta 2 equal, iso equal. Treatment for bronchospasm, well, that makes sense. Remember what beta 2 does? Beta 2, if you look right here, causes bronchodilation. So great thing to give somebody in the case of bronchospasm. Heart spasm, heart block, and bradyarrhythmias. Now, bradyarrhythmia means slow, so slow, irregular heartbeats. Well, that sounds good because if you look over here, this one right here increases the heart rate, beta 1. And since this does both the same, iso, B1, B2, it's going to help with those, help it go faster. Okay, now let's look at the beta 2 agonists. Okay, so now technically both of them did beta 2 here, but they focused mostly beta 1. So now beta 2 agonists, there's 4 of them, and it spells STAR, okay, S-T-A-R. The first one here is spelled di, beta 1, di. Beta 2, STAR. So sameterol, terbutaline, albuterol, and ritrodrine. Now, when you look at these, you've probably already heard of albuterol before, but we'll go over all of these. So sameterol, this is for treatment for asthma, has a long life, okay? Think of your friend Sam. Sam's really tall, really long guy, so he has a long half-life, okay? And it's for asthma. Sam has asthma. Next, terbutaline. Terbutaline is for treatment for asthma and premature labor. So this is a beta 2 agonist. You know, think about this. This makes sense why it's for asthma, because remember, beta 2 does bronchodilation. So this beta 2 agonist treats asthma. It has a long half-life. And terbutaline also treats asthma, and it's also for premature labor. Okay, well, that makes a lot of sense because you look right here, you see that this causes relaxes the uterus. Beta 2 relaxes the uterus. So you give the person terbutaline because they're in their you want them to get to the final stages of the baby before the baby's born. They want the baby to be fully developed. So you give them this terbutaline because when you're having a baby, it's very turbulent, and you want to slow down the turbulentness of their labor. And this has a short half-life, doesn't last very long. Next, albuterol. Okay, this has a short half-life, which is good because somebody like having an acute asthma attack, give them, they take the albuterol, and it calms it down, but just for a little while, just short, just works real quick. Next, ritrodrine, and this also is for premature labor. So terbutaline and ritrodrine, both for premature labor, but terbutaline is also used for asthma. Ritrodrine is just used for premature labor. Okay, next, the beta receptor antagonists. So what we have here, we have propranolol, which has a long half-life. Seeing if we've done that one before, but I guess not. Look familiar. So propranolol, long half-life, used in TH storm, so thyroid storm. I believe that's what that is, which means your thyroid's going out of control. And it prevents peripheral T4, T3 conversion. Yeah, so that's what that means, thyroid hormone storm. So a person is having crazy, their thyroid's it's releasing all this T3 and T4, or T4, I guess, and they take propranolol, and it calms down the thyroid hormone storm, and it is going to prevent peripherally T4 being converted to T3. T3 is the active form here. So it makes it so that T4, which is one of the thyroid hormones, T4 is what's released out of the thyroid, so the T4 can't turn back into T3, to be used, which is good. So going back here, it seemed like I'm remembering on one of the effects here is nope. Sorry, one moment. Looking for the one that affected thyroid. Yeah, not finding it. Apologize. Just kind of look back yourself. But anyway, this will last a little bit here. So prevents peripheral T4, T3 conversion. Esmolol has a short life, or a short half-life, excuse me. Acebutolol, atenolol, and pindolol, intrinsic sympathetic action, partial beta agonist. Labetalol and carvedilol has A1 antagonistic activity used in hypertensive emergency, and blocking A1 causes vasodilation, which makes sense because A1, if A1 is stimulated, then it's going to cause vasoconstriction. So if you block A1, it's going to cause vasodilation. Next, you have nadolol, which is used in the case of liver failure. It decreases visceral bleeding. Timolol and butexolol, which is open-angle glaucoma, decreases secretion of aqueous humor. Carvedilol and metoprolol, which decreases post-MI, myocardial infarction mortality. And sotalol, which is partial potassium channel activity, will increase the QT interval.